The books are open. The Miller is heavy physically and metaphorically. And the anxiety, well, let's just say the sympathetic tone is maxed out today.
I can imagine. It's a feeling every resident goes through.
I'm looking at this mountain of material, Miller, Morgan, Chestnut, plus all the lecture notes from the Gujarat University curriculum. And I'm realizing the obstetric anesthesia viva is a different beast entirely.
It really is.
It's not just pharmacology and tubes, it's interpretation.
Right.
It's two patients. And it's examiners who love nothing more than handing you a piece of graph paper with a squiggly line and asking, "Doctor, is this baby alive?"
It is the classic consultant's nightmare station. And you're right to feel the weight of it. In the MD exams, especially the Viva, they aren't testing if you can read a textbook definition.
No.
They are testing if you can think like an anesthesiologist when the monitor starts screaming. We're talking about fetal monitoring and APGAR scores today, but we are going to strip away the basic, nursing school definitions and look at this through the lens of physiology and critical decision-making.
That's the mission. That's exactly what I need. I don't need the definition of tachycardia so much as I need to know how to defend my management of it to an examiner who's been doing OB anesthesia for 30 years.
Exactly.
So I've got the source material spread out here. We're synthesizing the physiological depth of Miller with the clinical algorithms of Morgan, and we're going to pepper in those specific exam nuggets from the lecture notes, the things that get you the gold medal.
Perfect. Let's dive in, and we have to start where every good anesthetic answer starts, the physiology. So Part A, introduction and exam framing.
Okay, let's start with that fundamental idea, the two-patient concept.
Right. But let's nuance that for the exam. Miller makes a fascinating distinction here. If you're doing an appendectomy on a pregnant woman, the fetus is, for the most part, a bystander.
Okay, a bystander.
You keep the mom stable, the baby stays stable, but in labor, in the delivery suite. The fetus is the primary patient. You are effectively the in utero resuscitator.
I like that term. It completely reframes the role. I'm not just managing maternal BP. I'm actively managing fetal oxygenation through the mother.
Precisely. And to do that, you have to understand the supply line. This is the foundational concept for the entire Viva. If you understand uterine blood flow, you understand every single deceleration pattern we're going to discuss today.
A supply line. Okay.
So walk me through the hemodynamics of the uterus at term. What's special about it?
Okay, so at term, the uterine vasculature is essentially a maximal flow system. It's fully dilated.
Meaning, what's the implication of that?
Meaning it has very low resistance and, crucially, and this is the bit I always circle in my notes, it lacks autoregulation.
Yes, that is the million-dollar point. Unlike the brain or the kidneys, which can maintain their own flow even if pressure drops a bit,
the uterus can't. It's just a passive conduit.
It is a pressure-dependent system. It is a linear relationship. Maternal mean arterial pressure, your MAP, equals uterine blood flow. It's that simple.
So if the mother's pressure drops by 20%,
flow to the retroplacental space drops by 20%. There's no compensation, no backup plan.
Which is why the hypotension associated with spinal anesthesia is so dangerous. It's not just a number on the monitor. It's an immediate throttle on the baby's oxygen supply.
You've hit it right there. Precisely. Now combine that with the anatomy. The spiral arteries pump blood into the intervillous space. It's not a capillary bed like in a muscle. It's more like a lake.
Right, a lake where the maternal blood just bathes the fetal villi.
And that's where the gas exchange happens. But here is the kicker for the exam, the thing you need to state up front. The fetus exists on the brink of hypoxia, even in a best-case scenario.
Okay.
Do you recall the partial pressure of oxygen, the PaO2, in the umbilical vein?
It's shockingly low, something around 30 to 35 millibellucciato.
Correct. If an adult patient had a PaO2 of 30, we'd be intubating them without a second thought. But the fetus thrives on it. Why?
2 words, fetal hemoglobin, HbF.
Tell me about it.
It has that much higher affinity for oxygen. The oxyhemoglobin dissociation curve is shifted to the left.
The famous left shift. It grabs oxygen avidly from the mother's blood, even at low partial pressures. But there's a second, more elegant mechanism at play in that intervillous lake. They love asking about this in the theory paper.
The double Bohr effect.
Yes. Explain it to me.
Right, so this is the exchange mechanism. CO2 is moving from the fetus to the mother.
And that movement is what drives the oxygen transfer. So as the fetus dumps CO2 into the maternal blood,
its own blood becomes more alkaline, which makes its HbF hold on to oxygen even tighter. That's the fetal left shift getting stronger.
Good. And what happens on the mother's side of that lake?
That same CO2 enters the mother's blood. causing a local acidosis right there in the intervillus space.
Which does what to her hemoglobin?
It shifts her curve to the right, the classic Bohr effect, which makes her hemoglobin release its oxygen more easily.
Exactly. It is a perfect biochemical handshake. The mother is encouraged to dump O2, and the baby is primed to grab it. It's beautiful.
It really is.
But, and here is the clinical pearl, this entire system relies on the mother not being alkalotic systemically. If a laboring woman is in pain and she's hyperventilating,
Her systemic CO2 drops. She develops a respiratory alkalosis. Her whole body curve shifts left, so her hemoglobin starts holding on to oxygen more tightly.
and she clamps down her uterine vessels. A double whammy.
So when you place a labor epidural, you aren't just treating pain.
No, you are a resuscitator. By stopping that hyperventilation and normalizing her PASO2, you are physically shifting her dissociation curve back to a range where she can efficiently donate oxygen to the fetus. That is how you explain the advantages of labor analgesia to an examiner.
That's a very strong opening statement for a Viva station.
Oh.
Okay, so we've established the battlefield. The supply line is pressure dependent and chemically delicate. Now let's talk about how this all appears in the exam.
Good question. It's rarely just, what is a CTG? That's too simple.
It's always a scenario.
Always. A parturient with 39 weeks amenorrhea presents for an elective C-section. You place a spinal, and 5 minutes later, the FHR is 100 per minute. Discuss your management. That's a classic.
So you have to integrate physiology, pharmacology, and crisis management all at once.
And you need to structure your answer. For short note, you define, list components, draw a diagram. For a 15-mark question, you need headings: physiology, methods, interpretation, anesthetic implications.
And for the Viva.
For the Viva, you need to be slick. Start with a definition, state your immediate actions, and then explain the why behind them, referencing the physiology we just discussed.
Okay, that makes sense. So with that framework in mind, let's dive into Part B, fetal monitoring. This is the absolute essential core.
It is. So if I asked you to define fetal monitoring for the exam, how do you phrase it? Not just what it is, but what its goal is.
Okay, I define it by its objective. It's the surveillance of fetal heart rate and uterine activity with the primary goal of detecting signs of fetal decompensation, specifically hypoxic decompensation, early enough to allow for timely intervention.
Perfect. And add this phrase from Miller: to prevent permanent injury or death. That shows the examiner you understand the stakes. We are looking for intrauterine asphyxia,
which Morgan says is the most common cause of neonatal depression.
That's the one. So we have two main ways to do this in practice:
intermittent auscultation and electronic fetal monitoring, or the CTG.
Let's quickly touch on intermittent. It's the Pinard stethoscope or a handheld Doppler.
We see it in low-risk patients. You listen for a minute after a contraction, maybe every 15 to 30 minutes in the first stage, every 5 in the second, but it gives you very limited data points.
Exactly. It gives you a baseline rate, and you might hear a deceleration, but you can't assess variability. So for any high-risk patient or intraoperatively, the exam is going to focus on the CTG, the continuous trace.
Cardiography, fetal heart rate plus uterine contractions.
Right. And usually we're talking about the external trace, the Doppler transducer for the heart and the tocodynamometer for contractions. But let's pause on a technical nuance that examiners love to ask about:
the invasive option.
The fetal scalp electrode, or FSE. When do you abandon the external belt and reach for the FSE?
The most common reason is when the external trace is just unreadable. You know, maternal obesity is a big one, or if the mom is moving around a lot and you keep losing the signal.
That's the main one. But there's a more subtle reason.
If you need more detail.
Yes. If you need to analyze arrhythmias or, more importantly, get a precise beat-to-beat assessment of variability, the external Doppler averages the signal over a few beats. It's an approximation. It smooths things out.
Whereas the FSE is essentially a fetal ECG. It measures the RR interval beat by beat.
Exactly. So if you have a non-reassuring trace with minimal variability and you need to know if it's real or just artifact, the FSE is your gold standard. But you can't just put it on anyone. What are the prerequisites?
Well, the membranes have to be ruptured and the cervix needs to be dilated enough to get to the scalp. You can't put it on through an intact bag of waters.
Good. And contraindications, when would you absolutely not use one?
Any risk of vertical transmission of infection. So maternal HIV, hepatitis B or C, active herpes lesions. You don't want to create a portal of entry on the baby's head.
Perfect. Also, think about fetal bleeding disorders. It's rare, but if there's a known family history of coagulopathy like hemophilia or suspected fetal thrombocytopenia, you don't want to be screwing a wire into their scalp.
That seems obvious, but it's a detail that's easy to miss in the heat of a Viva.
And it's those details that separate the good answers from the great ones. Okay, now let's get to the meat of it. We're looking at the trace itself. We need to break down the components systematically. This is very, very high yield.
I use the mnemonic Dr. C bravado for this, but really it's the 4 pillars: baseline, variability, accelerations, and decelerations. And you're always interpreting them in the context of the contractions.
Excellent approach. Let's sprint through baseline first. What are the numbers?
Normal baseline fetal heart rate is 110 to 160 beats per minute.
Good. So tachycardia is?
Above 160, and bradycardia is below 110 for more than 10 minutes.
Let's dig into the causes. Fetal tachycardia. The textbooks list a dozen, but as an anesthetist, when you see a baseline creeping up to 170, what are your top 3 differentials?
Number 1 is maternal fever. Chorioamnionitis. That increases the fetal metabolic rate. The heart has to work harder.
Definitely number 1. What else?
Then drugs. Specifically drugs I might have given, beta agonists like terputolin or even ephedrine, atropine if it was used.
Yes, the sympathomimetics. And what about hypoxia?
That's the tricky one. Early mild hypoxia can actually cause tachycardia before it causes bradycardia.
Right. It's a compensatory response. Before the heart starts to fail, the sympathetic nervous system tries to compensate for low oxygen by increasing the rate. So a rising baseline can be an early, subtle warning sign.
Okay, what about bradycardia, below 110?
These are the scary ones. Your first thought is always profound, prolonged hypoxia. But what about our procedures?
Postspinal hypotension is the big one. If the mother's pressure tanks, that supply line gets squeezed and the baby's heart rate plummets.
Correct. And there's another rarer but absolutely critical one to mention in the exam.
Local anesthetic systemic toxicity. Fast damn.
Yes. That's a distinction that gets marks. Fetal bradycardia can be the first and sometimes the only sign of an accidental intravascular injection of an epidural dose.
Wow.
The fetal myocardium is much more sensitive to the depressant effects of bupivacaine or lidocaine than the adult heart. So if you top up an epidural, the mom feels fine, her BP is stable, but the baby's heart rate suddenly tanks to 80.
You have to consider that the catheter might have migrated into a vein.
You have to. It's a diagnosis of exclusion. That's terrifying, but it's an actionable thought that could save a baby's life.
Noted. Okay, now let's talk about the next pillar, variability. I feel like this is the concept that is the hardest to explain clearly, even if you know what it looks like on the trace.
Let's simplify it. Think of it as a neurological push and pull. The fetal heart is under constant warring control by 2 systems.
The sympathetic and the parasympathetic.
The sympathetic nervous system, the accelerator, wants to speed it up. The parasympathetic, through the vagus nerve, the brake, wants to slow it down. This tug of war happens beat to beat, second by second.
So if the brainstem and the autonomic nervous system are intact and well oxygenated, that war is active, and the line on the monitor looks wiggly or rough.
Exactly. That wiggle is the sign of a healthy reactive nervous system. We grade it.
Right. Normal or moderate variability is an amplitude of 6 to 25 beats per minute.
And that moderate variability is the single most reliable indicator of fetal well-being. It's more reassuring than anything else. It tells you the fetal brainstem is oxygenated, the lights are on, and the regulatory systems are home.
And if it goes flat, if you get minimal variability, which is less than 5 BPM, or absent variability, which is, well, a flat line,
then the war has stopped. Either one side has won, or more likely, the central command in the brainstem is depressed.
Okay, and why would it be depressed?
2 main categories of reasons. The first is the one we fear, severe hypoxia and acidosis. Essentially, the fetus is shutting down all non-essential activity to conserve energy and oxygen for the vital organs. It's a pre-terminal state.
And the second category?
The anesthetic confounders. The fetus could simply be in a deep sleep cycle.
Right. The sleep cycle is usually 20 to 40 minutes, but for us, it's usually our drugs. Opioids are the big one.
Pethidine, fentanyl, remifentanil, they all cross the placenta. They sedate the fetus just like they sedate the mother. So if you give a dose of fentanyl for pain relief and the variability drops...
You don't immediately rush to a C-section.
No. You note it, you watch, you wait. You can try stimulating the fetal scalp to see if it provokes a response. If it's just sedation, the variability will return as the drug wears off.
What about magnesium sulfate? We see that a lot in our preeclamptic patients.
A huge culprit. Mag sulfate is a CNS depressant. It flattens the trace. It reduces baseline variability significantly. If you're running a magnesium infusion for seizure prophylaxis or neuroprotection,
You have to expect a boring trace.
you have to. And you have to explain that to the obstetric team. It doesn't necessarily mean distress, but it removes your safety net. You lose that beautiful, reassuring wiggle, which makes interpreting everything else much harder.
Makes sense. Okay, third pillar, accelerations, the happy sign.
The happy sign. What's the rule?
The 15 by 15 rule, an abrupt increase in heart rate of at least 15 beats per minute, lasting for at least 15 seconds.
And what does it signify?
It's the hallmark of a reactive, non-acidotic fetus. It's somatic cardiac coupling. The baby moves, the heart speeds up in response. If you see accelerations present on a trace, especially in response to fetal movement,
You can be almost certain the fetal pH is normal, above 7.20. You can take a deep breath and relax for a moment.
because now we enter the danger zone, decelerations. This is where the Viva is won or lost.
It is. And this is where the physiology becomes absolutely critical. You cannot just memorize patterns. You have to visualize the mechanism. There are 3 main types, plus some variations, but the secret to identifying them is strictly their timing relative to the contraction.
So I need to be looking at the bottom strip, the tocodynamometer, and the top heart rate strip simultaneously. I can't look at them in isolation.
Never. Always interpret the heart rate in the context of what the uterus is doing. Let's start with the benign one. Type I, early decelerations. Describe the pattern to me.
It's perfectly synchronized. The contraction starts, the heart rate starts to drop, the contraction peaks, the heart rate hits its lowest point, the nadir. The contraction ends, the heart rate is back to baseline. It's a mirror image.
A perfect mirror image. And the mechanism. Why does squeezing the uterus make the heart slow down instantly?
It's not about oxygen, it's a reflex, it's head compression. As the uterus contracts, the cervix is squeezing the fetal head. This increases intracranial pressure.
Go on. Connect the dots for the examiner.
Okay, increased intracranial pressure leads to some dural stimulation, which triggers a direct firing of the vagus nerve. Vagal stimulation slows the heart.
It's a direct vagal reflex. Is there any hypoxia involved in this process?
No, the oxygen supply line is completely fine. It's just a simple, predictable reflex.
So what is the management for early decelerations?
Nothing. It's benign. It's actually a sign of good progress in labor. It usually happens late in the first stage or in the second stage. When the head is engaged and descending, you just document it and continue to monitor.
Perfect. Now, contrast that with the most ominous one, type 2, late decelerations. Describe the timing.
This is where the timing is shifted to the right. The contraction begins, and for a few seconds, nothing happens to the heart rate. Then, as the contraction is peaking or even starting to fade, the heart rate starts to dip.
And the nadir, the lowest point.
The nadir of the heart rate happens after the peak of the contraction, and the recovery back to baseline also happens after the contraction is finished. There's a lag.
This lag is the key. It's everything. Why is there a lag? This is your supply line failing under stress.
Okay, let me try to construct the physiology. During a contraction, the uterine muscle squeezes the spiral arteries, which temporarily stops or reduces blood flow into that intervillous lake.
Right. For those 60 to 90 seconds, the fetus is essentially holding its breath. It's relying on the oxygen reserve already sitting in the intervillous space.
If the placenta is healthy and functioning well, there's plenty of reserve oxygen in that lake. The baby doesn't even notice the temporary stop in flow.
But if there's uteroplacental insufficiency, if the placenta is old, calcified from smoking, or damaged by preeclampsia or diabetes, that oxygen reserve is tiny. It runs out halfway through the contraction.
So the tank empties. The fetus becomes hypoxic during the squeeze.
Exactly. Now, walk me through the reflex arc that follows. Why does the heart slow down? It's not the vagus nerve this time.
Okay, so hypoxia develops. The chemoreceptors in the fetal carotid body detect the low O2. They fire a warning signal.
And what's the response to that signal?
It triggers a protective sympathetic surge. But it's not to speed up the heart. It's to clamp down all the peripheral blood vessels, to shunt the remaining oxygenated blood to the most vital organs, the brain, the heart, the adrenal glands.
Good. And that massive peripheral vasoconstriction causes a huge spike in the fetal blood pressure.
Right, which then triggers the baroreceptors in the aortic arch. They sense this dangerous hypertension, and their job is to protect the heart. So they fire, triggering a reflex bradycardia to lower the pressure.
Perfect. A chemoreceptor-mediated, baroreceptor-affected bradycardia. And because it takes time for the oxygen to run out, time for the chemoreceptors to fire, and time for the whole reflex to kick in, the drop in heart rate appears late relative to the contraction.
And crucially, the recovery is also late and slow. Even after the contraction ends and blood flow returns, the fetus has to repay the oxygen debt, wash out the lactic acid and other metabolites before the heart rate can come back up to baseline.
So if you see early decelerations, you think head compression. If you see late decelerations, you must think hypoxia.
They're the sign that metabolic acidosis is developing. If you see recurrent late decelerations, the fetus is failing to compensate. This requires immediate action.
Yes. Uterine resuscitation, and if that fails, a very rapid delivery. Okay, last of the main three. Type 3. Variable decelerations. Describe their look.
These are the most common ones. They're jagged, sharp, and, as the name implies, variable in their shape, size, and timing. Often they look like a V or the W or a U.
And the pathophysiology?
This is the kinked hose pipe. This is an umbilical cord compression. The timing varies because the cord can get squashed at any point, not necessarily in a uniform way with the peak of the contraction.
Right. But here's the advanced detail for the MD student. To assess the severity and well-being of the fetus during a variable, you look for the shoulders.
The little accelerations before and after the big drop.
Why are they there? It's the physiology of occlusion. Picture the umbilical cord. It has one big, floppy, low-pressure vein and two smaller, muscular, high-pressure arteries.
Okay.
When the uterus starts to squeeze the cord, what collapses first?
The thin-walled vein.
Right. So venous return of blood to the fetal heart stops abruptly. Preload drops. How does a healthy fetus compensate for a sudden drop in preload to maintain cardiac output?
It increases its heart rate. A reflex tachycardia.
That's the first shoulder, a brief acceleration. Then, as the squeeze gets harder, the thick-walled arteries are compressed and occluded.
Okay, so now the fetus is pumping against a brick wall. Afterload spikes massively.
And the baroreceptors scream, "Too much pressure!" And the vagus nerve slams the brakes on the heart to protect it. That's the massive sharp drop, the V of the variable deceleration.
And then the reverse happens as the contraction eases.
Exactly. The squeeze releases, the arteries open first, afterload plummets, and you get a second brief acceleration, the second shoulder. Then the vein opens, preload is restored, and the heart rate returns to baseline.
That makes so much sense. So the presence of those shoulders is actually a good sign. It shows the physiological struggle, but it also shows the autonomic nervous system is reacting perfectly.
It's a reassuring variable deceleration. You're more concerned when the shoulders are gone, or if the deceleration drops by more than 60 beats, or lasts for more than 60 seconds, that suggests the fetus is losing its ability to compensate.
Okay. Before we move on from the CTG, we need to briefly mention the most sinister pattern of all.
The sinusoidal pattern.
Yes, describe it.
It's a smooth, regular, undulating wave-like pattern. It looks like a perfect sine wave from a math textbook, usually around 3 to 5 cycles per minute, with no beat-to-beat variability.
It looks rhythmic, almost hypnotic on the screen.
It's the rhythm of a dying brainstem. It signifies profound fetal anemia or severe hypoxia and acidosis. The normal regulatory centers have shut down completely.
So what are the causes?
Think severe anemia, Rh isoimmunization, or a massive fetal-maternal hemorrhage, or something catastrophic like a vasa previa rupture where the baby has acutely bled out into the mother.
So if you see this, it's an emergency.
A Category 1, get the baby out now emergency, but there's one exam trap.
The drug effect.
Yes. Certain opioid analgesics, particularly butorphanol, which isn't used as much anymore, can cause a pseudosinusoidal or mock sinusoidal pattern. It looks similar, but it's transient and drug-induced.
So if the examiner shows you a sinusoidal trace, your first question should be,
what drugs has the mother received in the last hour? If the answer is none, you activate the emergency C-section protocol and call the blood bank to have O-negative blood ready for the baby.
Okay, wow. I feel like I have a much better framework for the trace now. It's not just lines, it's hemodynamics and neurology.
Yeah.
Let's shift gears to when the baby is out. Part C, the APGAR score.
Dr. Virginia APGAR, 1952. An anesthesiologist, we should proudly note, she wanted a simple, reproducible way to quantify the condition of a newborn immediately after birth.
It's essentially the Glasgow Coma Scale for babies, a quick assessment of their physiological state.
Exactly. It's scored at 1 minute and 5 minutes of life. And if the score is low, you continue scoring every 5 minutes up to 20 minutes.
Now, just like the GCS, there are traps. And for APGAR, the biggest one is the resuscitation trap.
I cannot stress this enough. If you are in a Viva and you say, I will calculate the APGAR score to decide if I need to start resuscitation, you will fail the station.
Because it takes a full minute to calculate the 1-minute score.
And in a floppy, apneic baby, 1 minute is an eternity of hypoxia. Resuscitation begins in the first 30 seconds of life. It's based on the neonatal resuscitation program, the NRP algorithm.
Which is based on 3 simple questions.
Is the baby breathing or crying? Is the muscle tone good? And is the heart rate above 100? If the answer to any of those is no, you start resuscitation, usually with positive pressure ventilation. You assign the APGR score retrospectively while you are working.
So a report card, not a triage tool.
An excellent way to put it. It tells you how the baby responded to delivery and to your resuscitation efforts. But you must know the table cold for the exam. APGAR. Let's do a rapid fire.
Okay. Appearance or color. 0 is blue or pale all over. 1 is pink body with blue extremities, which is acrocyanosis. 2 is completely pink. Pulse or heart rate. 0 is absent. 1 is less than 100 beats per minute. 2 is greater than 100. And this is the most important line item, right?
It is absolutely the most critical component. The heart rate is the primary driver of your resuscitation success and the best indicator of recovery.
G.
Grimace. This is reflex irritability. You test it by suctioning the nose or flicking the sole of the foot. 0 is no response. 1 is just a grimace or weak movement. 2 is a vigorous cough, sneeze, or a good cry.
E for activity.
Muscle tone. 0 is limp, a ragdoll. 1 is some flexion of the extremities. 2 is active, spontaneous motion.
And finally, R.
Respiration. 0 is absent, apneic. 1 is slow, irregular, or gasping. 2 is a good, strong cry.
Perfect. And remember, for your exam, a total score of 10 is actually quite rare.
Because almost all healthy newborns have some transient acrocyanosis in the first few minutes due to peripheral vasoconstriction while they adapt.
Exactly. So they get a 1 for color. A perfect 9 is the standard for a vigorous, healthy baby. Don't let an examiner trick you on that.
Noted. Now, interpretation of the score. It's straightforward. A score of 7 to 10 is considered normal or vigorous, routine care. 4 to 6 is moderately depressed. This baby likely needs some help, maybe supplemental oxygen, stimulation, or brief positive pressure ventilation.
And 0 to 3 is severely depressed.
This is a baby that needs immediate advanced resuscitation, intubation, chest compressions, maybe drugs like adrenaline.
Okay. But now let's talk about the limitations. This is another favorite exam topic.
Yeah.
Let's play the defense attorney. You're in court. The plaintiff's lawyer says the baby had an APGAR of 3 at 1 minute. The anesthetist was clearly negligent and caused birth asphyxia. What is your defense?
My first point would be that the APGAR score is nonspecific. A low score describes the condition of the baby at that moment, but it does not tell you the cause of the condition.
So it does not automatically mean asphyxia?
Absolutely not. So give me some alternative explanations for a low APGAR score.
Okay, number 1 for us would be drugs. If I just gave a general anesthetic for a crash section, the baby will be exposed to propofol, volatiles, maybe opioids. They will come out limp and not breathing.
So they'll score low on tone, respiration, and grimace.
But that's not hypoxic brain damage. That's reversible drug depression.
Exactly. What else?
Prematurity. A 28-weeker is neurologically and muscularly immature. They cannot have the same active tone or vigorous cry as a term baby. They lose points just for being born early, not because they were asphyxiated.
Excellent point. It's not a level playing field. Any others?
Congenital conditions. A baby with a congenital myopathy or a neurological problem. Or congenital sepsis, which can make them very flat. Or even trauma from a difficult delivery.
All valid points. The APGAR is subjective. It's affected by maturity, drugs, and congenital issues. And importantly, for the long term, while it has some correlation, it's a very weak predictor of long-term neurological outcome, like cerebral palsy.
Right. The 1-minute score correlates best with acid-base status and immediate survival, while the 5-minute score has a slightly better but still weak correlation with neurological outcome.
You've got it. So now let's connect the two big topics. Part D, fetal monitoring versus the APGAR score. How do they relate?
The distinction is simple, really. It's about the time frame.
Explain.
Fetal monitoring is antepartum or intrapartum. It's a movie. It's a continuous surveillance tool. It's predictive, or at least we hope it is. Its goal is to prevent injury.
Good. And the APGAR?
APGAR is postnatal. It's a snapshot taken at 1 minute and 5 minutes. It's retrospective and evaluative. It tells you how well the delivery and your resuscitation went.
The movie versus the snapshot. I like that analogy, and ideally they correlate. A Category 3 trace, the bad movie, should lead to a low APGAR score. The bad snapshot.
But it doesn't always. The fetus has incredible reserve. You can have a terrible-looking trace with late decelerations, you rush to a crash section, and the baby comes out screaming with an APGAR of 9.
Which is a win. That means the movie told you the ending was going to be bad, and you intervened in time to change it.
Right. But the reverse is the real nightmare. A perfectly normal category I trace throughout labor, and then a sudden, unpredictable event right at the end.
Like a shoulder dystocia or an acute cord prolapse during pushing.
Exactly. The movie was fine, but the last scene was a disaster, and the baby comes out flat with an APGAR of 2.
There are two different pieces of the same puzzle, looking at different time frames. The anesthetist is the one who has to bridge that gap and manage the transition.
Which leads us perfectly into Part E, anesthetic implications. As an anesthetist, our job is to optimize that transition. So let's talk practical management. First, our general role in fetal well-being.
Our primary role is the maintenance of maternal physiology to protect that supply line. It comes down to 4 key things. Number 1, oxygenation.
Prevent maternal hypoxemia at all costs.
Yeah.
Pre-oxygenate, use supplemental oxygen. Simple but critical.
Number 2, blood pressure.
Avoidance of hypotension. This means aggressive, preemptive treatment of postspinal hypotension.
Number 3, position.
This is the easiest and maybe the most important intervention. Left uterine displacement. Manually or with a wedge. Get that heavy uterus off the aorta and the vena cava to maintain cardiac output.
That is the single most mentioned intervention in every textbook for a reason. And finally, number 4, drug choice.
Thinking about what crosses the placenta. Avoiding high doses of sedatives or opioids close to delivery to preserve the baby's respiratory drive and the APGAR score.
Exactly. But what happens when things go wrong? Despite our best efforts, the trace goes bad. We see recurrent lates or a prolonged bradycardia. We need to perform intrauterine resuscitation. This is the code for the fetus.
And you need a mental checklist for this. Because when the fetal heart rate alarm is screaming and the heart rate hits 60, your own IQ drops by 20 points. You need to be robotic.
Absolutely. So what's step 1?
Call for help. Announce the problem to the obstetrician, the midwife, the pediatrician.
Good. Step 2.
Position. Immediately put the patient in the left lateral position or apply manual left uterine displacement.
Step 3.
Oxygen. High flow oxygen, 100% via face mask. Even if the mother's sats are 98%, we need to maximize the pressure gradient to drive oxygen across the placenta.
Step 4.
Fluids. Open the IV wide. A bolus of crystalloid to fill the tank and support the blood pressure. Stop the stress. Turn off the oxytocin or syntocinon infusion. The contractions are the problem, so let's stop them.
And sometimes just stopping the oxytocin isn't enough. What's step 6?
If the uterus is hyperstimulated, clamping down in what we call tachysystole, you need to give a tachycardic.
Like what?
A shot of nitroglycerin, maybe 50 to 100 micrograms IV, or terbutaline. Something to relax the uterine muscle, stop the squeeze, and allow the spiral arteries to fill again.
Good. And simultaneously, you are treating any hypotension. Now, this is where the guidelines have shifted over the years, and it's a vital point for your exam. Phenylephrine versus ephedrine.
This is a huge one. For decades, we were all taught ephedrine is better in obstetrics because it preserves uterine blood flow.
That has been comprehensively debunked. Miller and Chestnut are both very clear. Phenylephrine is a vasopressor of choice for treating maternal hypotension.
So why the change? What's the new understanding?
It's about what the drugs do to the fetus. Ephedrine is a mixed alpha and beta agonist, and it crosses the placenta. It stimulates the fetal beta receptors. It effectively gives the fetus a shot of adrenaline.
So it whips the fetal heart, increasing its metabolic rate and its oxygen consumption.
Precisely. In a baby that is already hypoxic and becoming acidotic, ephedrine forces it to run a marathon just when it needs to be conserving energy. It can actually worsen fetal acidosis.
Okay, that makes sense.
Phenylephrine, on the other hand, is a pure alpha agonist. It works primarily on the maternal alpha receptors to cause vasoconstriction. It raises maternal pressure, which restores flow to the uterus, but it doesn't significantly cross the placenta or stimulate the fetus.
So it improves the oxygen supply without increasing the fetal demand.
The perfect combination. That is a definite exam point that has changed from 10 years ago. Stick with phenylephrine. If you perform all those intrauterine resuscitation steps and the trace doesn't recover,
then you prepare for an emergency delivery, usually a Category 1 cesarean section.
And your choice of anesthetic, a rapid sequence general anesthetic versus topping up a working epidural, will depend on the urgency, the maternal status, and your airway assessment.
Okay. I think that covers the practical side. Finally, let's move to Part F exam integration. Let's talk about how to present all this information on the paper or in the Viva.
Let's start with the common traps. We've mentioned the wait for APGAR to resuscitate trap. What's another big one?
The cause of bradycardia trap.
Yes. If they ask, what is the most common cause of fetal bradycardia after a spinal anesthetic? Don't just say the spinal. Be more precise.
You should say maternal hypotension secondary to the sympathetic blockade from the spinal anesthetic. Treat the mother to treat the baby.
Perfect. It shows you understand the mechanism, not just the association. Another trap is visually confusing decelerations.
Variable versus late, especially on a messy trace.
They can look similar. The key is to look for the shoulders on a variable and look for that consistent, smooth, delayed nadir on a late. Don't be afraid to take a ruler or a piece of paper to the trace to line up the peaks and nadirs.
Okay. What about diagrams? I feel like in the written exam I should be drawing.
Absolutely, 100%. If you are asked to write a short note on decelerations, you must start by drawing the 3 types. It's easy.
How would you do it quickly?
First, draw 3 identical contraction hills on the bottom half of your diagram space. Label it uterine contractions. Then, for early, draw the heart rate dip directly above the hill, a perfect mirror image. For late, draw the dip shifted to the right with its nadir after the contractions peaked. For variable, just draw a sharp V shape with little shoulders on either side.
And label everything, nadir, lag time, etc.
Yes. Examiners love diagrams because it shows you can visualize the concept, not just write words about it. It's a quick way to score maximum marks.
And for the APGAR score and a written answer.
Don't just write it out in a paragraph. Draw the table. Write the mnemonic APGAR vertically down the side. Make columns for scores 0, 1, and 2. Fill it in. It takes 30 seconds, it's clean, and it ensures you don't forget grimace or mix up the heart rate cutoff.
That's very practical advice. Okay, let's wrap this entire deep dive up with a high-yield summary. The elevator pitch for the exam.
Here is your closing argument. If you remember nothing else, remember these points. 1.
Fetal monitoring is all about surveillance of the fetal supply line.
2.
That supply line is pressure dependent because the uterine circulation has no autoregulation.
3.
Decelerations are the language of the distressed fetus. You must learn to interpret them.
And the translations are?
Early decels are head compression. Late decels are uteroplacental insufficiency or hypoxia. Variable decels are cord compression.
Good.
4. Variability, specifically moderate variability, is the single most important sign of fetal well-being.
5.
The APGAR score is a retrospective report card of the baby's condition. It does not guide the initiation of resuscitation.
And finally, 6. The most important one for us.
The anesthetist is the guardian of maternal physiology. Our job is to protect that supply line by maintaining blood pressure, preferably with phenylephrine, maintaining left uterine displacement, and optimizing oxygenation.
That's your exam answer in a nutshell.
That's strong. I actually feel calmer. I feel like I can explain why a late deceleration happens instead of just memorizing the fact that late is bad.
And that is the difference between a resident who is passing and a resident who is excelling. It's the difference between being a student and becoming a colleague. You understand the physiology.
Okay, I'm going to go visualize some CTG traces and practice drawing the mirror image of an early deceleration until I can do it in my sleep.
Go crush that exam. You have the knowledge. Now go get the degree.
Thanks. And to everyone listening, good luck with your prep. You've got this. The deep dive is rooting for you.
Good luck.
See you on the other side of the pass list.